people of the Eora Nation. It is upon their ancestral lands that the University of Sydney is built. As we share our own knowledge, teaching, learning and research practices within the university, may we also pay respect to the knowledge embedded forever within the Aboriginal custodianship of country. Thank you very much. Sorry. Welcome everybody that's online today. And this workshop today is actually the third in a series of nano innovation technology workshops that have been planned for 2022. It's held in conjunction with the SaveSight Institute, and they've been leading the way in finding new solutions to prevent and treat eye diseases of all kinds. With Sydney Nano, who are leaders in nanotechnology. And why we're here today is because eye disease is a growing burden for patients, but also for the health system and society. As our global environment changes, it's increasing the prevalence of certain eye diseases and also the burden from these diseases. So we need to be ready. We need to be ready with new solutions and treatments. And nanotechnology provides a very elegant way of addressing many of these problems. We need to meet the current challenges, but also prepare for the future. Our speakers today will give insight into the current state of what we need to do, what the problems are, and also how we might address them in our changing environment. Firstly, we're going to open with a global perspective. And I'd like to introduce Jude Stern from she's a global educator and knowledge broker with extensive experience working on the intersection of global eye health and international development. And she's head of knowledge management at the International Agency for the Prevention of Blindness. Following Jude, we'll hear from Mitasha, who's a dynamic consultant for the World Health Organization Vision and Eye Care Program, with a focus on human resource development in the eye care sector and working on development tools such as the Eye Care Competency Framework to support the implementation of recommendations of the newly launched World Report on Vision. But let's begin with Jude. Welcome, Jude.
Thank you, Stephanie. Thanks so much for inviting us here today. It's really delighted to be a part of the Sydney Nano workshops. And as you mentioned, my name is Jude Stern. I'm Head of Knowledge at IAPB. I'm presenting to you today from the land of the Gadigal people of the Eora Nation, and I'd like to acknowledge the traditional owners of the land and pay my respects to any Aboriginal and Torres Strait Islanders who join us here today. I'm delighted to be able to present on global eye health to this forum. It's exciting. It's nice to see a few familiar faces and lots of new faces. And today I'm going to look at the challenges and opportunities in global eye health and have a little look at the 2030 Insight sector strategy for addressing those challenges so that by the end of the next decade, we aim to ensure that no one experiences unnecessary or preventable sight loss. And as a result, everyone can achieve their full potential. So I'll just share my screens. I have some slides for you. Just 1 second. Okay. So just as an introduction for anyone that doesn't know IAPB, IAPB is the overarching alliance for the global eye health sector, made up of more than 180 members across 100 countries in the world, and really spanning all different types of organizations and groups that work in global eye health and development. IAPB's role is one around global collective advocacy, connecting knowledge and strengthening the network. And in these areas, we look to raise the profile of eye care with key international institutions, so it receives the attention and resources needed to achieve universal access to eye health. We're very focused at my area, my particular area is connecting knowledge, providing authoritative data and information, and enabling access to up-to-date knowledge, information, and practice, and to build partnerships to catalyse systems change and build coalitions to broadly integrate eye care in health and beyond. So today I'll start talking about the challenge and the global burden of vision loss in our world. Globally, almost everybody on the planet will experience an eye health issue in their lifetime. And I did see that something came out in Australia yesterday around that for the Australian statistics. But globally, more than 1 billion people worldwide are living with sight loss primarily because they don't have access to the eye care that they need. Additionally, at least 1 more billion people live with eye care conditions that need services constantly. This is a huge load. Sadly, over 90% of vision impairment that is currently in the world, or people living with vision loss in the world, is avoidable. That is, it could have been prevented or is yet to be treated with some of the most straightforward and cost-effective interventions that exist, such as cataract surgery and a pair of glasses for uncorrected refractive error. Eye care is still under-resourced and unaffordable for too many people. We have over 800 million older people across the world living with preventable vision loss that have little or no access to eye care. And like most health conditions and many things in the world that we live in, sight loss is not born equally. 90% of people living with sight loss currently are in low and middle income countries. In that group, almost around 2/3 live in the South Asia, Southeast Asia and Oceania region, which is important for us sitting here in Sydney to acknowledge and be aware of. Similarly, rates of blindness were up to 9 times higher in Western Sub-Saharan Africa than in North America. Another area that I'm sure most people on this call are familiar with is that vision loss affects people primarily over 50 years of age. So almost 3/4 of vision loss is seen in the older age groups, and the rates of vision loss increase for every decade over 50 years. We also see inequalities in gender, with 55% of women and girls, sorry, 55% of the people with vision loss are women and girls, and that translates to 609 million women and girls out there with vision loss, and compared to 497 million men with vision loss. Both are significant and both need to be addressed. And similarly, with most inequalities, rural populations, people with low incomes, older people, people with disabilities, Indigenous people and ethnic minority groups are most likely to suffer from sight loss and the wider implications that that entails. And as we know, this burden and challenge is growing. If we leave it unchecked at the moment, it is projected that 1.8 billion people will have sight loss, live with sight loss by 2050. And this is primarily due to changing causes of sight loss, or changing main causes, with non-communicable diseases on the rise, lifestyle changes and aging populations. Diabetic retinopathy is a key area where we're seeing a large growth in vision loss across the world when we compare countries with age standardized prevalence. And again, the burden is larger in low and middle income countries. On top of this, half the population is set to have a vision impairment, specifically myopia, by 2050. This is a trend that we've seen exacerbated during COVID-19. We also know that unless there's significant investment in eye care services, we're unlikely to cope with the future needs of the population. Sorry. We do know, as the Lancet Global Commission for Global Eye Health showed us earlier, when it was released about a year ago, has shown that eye health clearly has a much wider impact on the economy, education, inclusion, and more. Vision and eye health cuts across many of the Sustainable Development Goals, from poverty reduction to economic growth and employment, to education, gender, and reducing inequalities. And you can see from this diagram out of the Lancet article that vision and eye health can be an enabler of achieving SDGs, and it can also cause problems with achieving SDGs. And just one example of the impact, the Lancet estimated last year that there's a yearly cost to the global economy of $411 billion in lost productivity alone for the people that are currently living with vision loss. And poverty is both a cause and a consequence of poor eye health. We can now prove that improving eye health helps reduce poverty, unlock better educational outcomes, and create better employment prospects, increasing productivity at work and promoting greater gender equity. And you can see on this slide here that there's quite a number of studies that are showing those different links, pointing out when we often talk about eye health, it's pushed down the health agenda because it's not considered to be life-threatening. However, poor eye health increases the risk of mortality up to 2.6 times. I think no surprise for anyone here, the impact that addressing eye health can have on quality education is enormous, and similarly on being able to earn an income. And the one that we wanted to talk about today, and that Mitasha will talk about and focus on today, is the climate action. There are growing evidence of the links between eye health and climate action and climate change, which Mitasha will outline in her talk, so I'm not going to touch on that now. And we're very thrilled to have Mitasha as our co-chair for our climate action work group as part of IAPB. And I think the group and members of that group have really led a lot of research and action in this area over a number of years and brought it together under the IAPB umbrella so that they can connect and share that more broadly. And when we take it back to a very individual level, we know that eye health is essential to get an education, earn a living, and maintain our well-being. So for the reasons of this interconnectivity, there's been the first UN resolution on vision that was made last year, explicitly linking eye health to 8 SDGs. And this is the first time in the UN history eye health has even been mentioned. Since this resolution, just a couple of weeks ago, eye health is now high up in the driving resolution, a resolution on driving, and eye health is now a very important part of that. There's discussions over a couple of other resolutions that are going on to incorporate eye health into them. And it shows how important it is to actually be on the agenda, to be a part of the solutions. The global eye health sector has a new strategy, 2030 in sight, to look at eye health for the next decade. It builds on so much of the great work that was already done through Vision 2020 and other initiatives. It recognises there is still so much more to do, and we need to work differently to make sure eye health receives the global political, health and development priority it needs and deserves. In the strategy, it sets out 3 objectives by 2030. We want to see a world where no one experiences unnecessary or preventable sight loss. One where eye care and rehabilitation services are accessible, inclusive and affordable to everyone, everywhere. And that people understand the importance of caring for their own eye health and demand access to services free from the weight of any social stigma. Equity, if I can say that, really emphasize that equity must be at the heart of everything that we do. The strategy, which I'm not going to go into any more detail than this on, has 3 core elements, which is to elevate eye health, to embed vision as a fundamental social, economic and development issue, to integrate eye health so that it is incorporated across health broadly, widely, so that it's accessible to all, and to activate patients and consumers and markets to be able to demand eye care that is needed. As part of the strategy, and what I wanted to point out particularly today, is we have 10 priorities of how we need to work differently. And whilst these are all important to discuss and probably all resonate with different people here for different reasons, I wanted to just point out the embraced technological solutions. It's been identified in quite a number in the strategy and a number of publications that if we don't embrace technology and harness the potential that it has, we won't be able to scale and reach the number of people that is needed to across across the eye health burden. And this is a core area of work that we're going to be looking at IAPB, and we're very excited to connect with Sydney Nano and SafeSight Institute around this. In the Lancet Global Commission for Eye Health, in relation to technology, it was obviously acknowledged the potential, but also to take note, to make sure that that anything we're thinking about in technology is designed and considered to maximise the potential to improve coverage, accessibility, quality, efficiency, and affordability of eye care services and solutions, to ensure that all populations can benefit from these developments. At IAPB, we have a technology task force that has started to look at this area, and it's very exciting to connect in with the nanotechnology community, because that's not an area we have on our task force. And so I really look forward to hearing the talks that the other speakers are going to give today and the discussions, and how to think about how and where nanotechnology can fit in with the global eye health agenda and workforce. We have a lot of other groups that I think would be interested to know that too. So I'd like to thank you for inviting me here to speak today. Thank you for your time. And I guess I hand back over to you, Stephanie.
Thank you very much. That was fascinating, and I look forward to the discussion. But first, we're going to hear from Mitasha Yu. And if anyone has any questions, we'll get to that after her talk. So you can pop them into the chat if something comes to mind, and then we'll address them at the end of this talk. Thank you.
Thank you, Stephanie, and thank you, Jude, for doing that great introduction. I'm just going to share my screen, and hopefully everyone can see that. But today, as Stephanie and Jude have mentioned, that I'd like to talk to you about the linkages between climate change and eye care, and give you a broad overview of what's happening in the eye care sector globally. So this photo you might all be a bit familiar with. This happened a couple of years ago in our backyard, that Sydney and New South Wales felt like half the country was burning down. And this is just a devastating example of some of the immense damage that's happening to our environment globally. There's more extreme weather events, whether it's rising sea temperatures, sea levels, spread of disease, devastation in habitats, and increase in air pollution. It's sort of why we need to act on climate change. In the last 2 years, the devastating facts have been presented by reports from the Intergovernment Panel on Climate Change. And they stated that human activity is unequivocally the cause of rapid changes to the climate. So the science is strong, and it warns that there'll be even more widespread extreme weather events in the future. Unfortunately, that means it disproportionately impacts poor and vulnerable people. That includes women and girls, people with disabilities, including vision impairment and blindness, and people living in remote and rural communities. We have to really think about climate change not as just an environmental issue, but also a health and development issue. So how does it impact our health? So this picture in front of you is just showing an overview of the identified climate-sensitive health risks, the exposure pathways, and vulnerability factors. The figure shows that climate change impacts both directly and indirectly, and is strongly mediated by the environment, social, and public health determinants. And the bad news is that climate change is leading to death and illness, with some examples, as you can see in the bottom there, that is leading to heat-related illnesses. We're seeing heat waves all across the Northern Hemisphere right now, breaking records. There's respiratory illnesses, with air pollution estimated to cause 7 million preventable deaths globally each year. And there's also waterborne, vector-borne diseases, malnutrition, non-communicable diseases such as diabetes, and also effects on mental health. Climate change is really undermining many of the social determinants for our good health, such as our livelihoods, equality and access to healthcare, and social support structures. So if we bring it down now to the eye care level, how does it impact our eyes? So there is limited data around this, but what we are seeing is that there will be a predicted or likely increase in ocular infections such as trachoma. where many of these countries have actually limited trachoma, but we are likely to see an increase in that due to water contamination and poor sanitation. An increase in cataracts and ocular lesions or cancers of the eye due to excess UV, an increase in allergic eye disease, glaucoma, age-related macular degeneration due to poor air quality and air pollution, and a disruption of eye care services due to extreme weather events. In times of crisis, only core health services are usually prioritized, which often leaves out eye care. And we saw that happening during the COVID-19 pandemic, where we saw almost universal suspension of crucial eye health services such as cataract surgeries, diabetes eye care, and distribution of glasses to address the refractive error need that there is. So if you combine the disruption to the critical eye services and the predicted increase in eye disease, the situation will only worsen. And now if I talk about how eye care contributes to climate change. So I've talked about how climate change affects our health, affects our eye health. And now how does eye care as a sector contribute to climate change? Globally, healthcare is a massive consumer of resources and a major emitter of greenhouse gas emissions. We're responsible for 2 billion tons of carbon dioxide equivalents, which is about 4.4% of all global greenhouse gases. It's like running 514 coal power stations, and Australia is actually higher than that. It's 7% here. The health sector alone, if it was considered a country, would be the 5th largest emitter. And that's sort of hard to digest, but it sort of places this enormous responsibility on the health sector to both recognize and act on the emissions that we are causing. So among the different ways that the health sector contributes to emissions, I'm going to talk about 2 brief ways, and that's through unsustainable procurement and poor waste management. If you can see that graph in front of you, you can see that in this study, they looked at a cataract surgery that was performed in India versus a cataract surgery performed in UK. Exact same cataract surgery method, but you can see in the India example, it only produced 5% of the carbon emissions compared to the one in UK. However, in both cases, you can see that sustainable procurement or unsustainable procurement is actually the leading cause driving up the carbon emissions. And in looking at poor waste management, you can see that in this example, again, the study looked at this cataract surgery done in UK versus cataract surgery done in India. And the same surgery yielded 30 times more waste when it was done in UK. So just looking at these 2 examples, you can see that how we carry out our eye care activities really determines how we contribute and the carbon is emitted through our contribution. Now, I just want to briefly talk about the shift in energy we're seeing globally. There's a strong momentum from leading international agencies. So Jude mentioned the Sustainable Development Goals. The UN declared a climate emergency in 2015, and the 17 Sustainable Development Goals that they established, many of them are around the environment, and Sustainable Development Goal number 13 is specifically talking about climate change and about the urgent action that we need to take. Then we have the World Health Organization, which is really looking at climate change from a health perspective and has said that it affects the social and environmental determinants of health. And they have a recent focus on supporting health systems to become more climate resilient and sustainable. And the Lancet Commission on Global Eye Health has added that planetary health is a key component of improving quality of eye care, and they consider environmentally sustainable eye health services to make progress towards this SDGs. And another point I'd like to add is around just organization. There's this growing body of movement that directors and boards of companies cannot continue to ignore the role they play in contributing to climate change, nor the risk that climate change poses on their worker and on their business due to the financial risk that they pose and the long-term value to shareholders. So these shifts that's happening around us as a sector in eye care, we don't want to be left behind. And the good news is we're not going to be left behind. We have a lot of great momentum that's happening in the sector. We have a climate action work group that Jude mentioned that we have set up. It meets regularly as active members from across the sector that look at priority areas relating to climate change and eye health and how we can promote this within the sector and also develop resources to support the sector to take action. We worked together so that the sector declared a climate emergency last year, and it really shows that we're committed and united to saying that we want to do more on this matter. And Jude also mentioned about eye health being linked to the Sustainable Development Goals. So that now that the UN has endorsed that link, we can really say that there is that cut across economic, social, and environmental domains within eye care. And so it just brings that message home stronger that we need to do more in this space. So what can we do? So after we've seen all this talk about this is the problem, you know, it's immense, and how do we go about actually doing something? So at the Climate Action Working Group, we've actually developed a couple of resources that summarize some of the key activities that we can be doing. And this is in the call to action and the guide for environmentally sustainable practices in the eye health sector. And we've summarized it in 10 key areas of action. And I'll just list these here, but I will go into detail in a few of them just to explain how the guide works. So the first is lead, second is advocate, 3 is procure sustainably, reduce the use of fossil fuels, conserve water, reduce and safely dispose of waste, reduce and green the travel, follow the 4 principles of sustainable clinical practice, embed environmental sustainability in education, and focus research. So I'm going to share with you 3 case studies of what's actually already happening in the sector. The first key action area I want to focus on is reduce the use of fossil fuels. It's a very easy, low-hanging fruit that everyone is talking about. We need to cut down fossil fuels. And health facilities, hospitals, they have large energy demands. They have to continuously operate. They need to have increased heating, ventilation, air conditioning, running critical life-saving equipment. So they really need the sustainable power to continue its operations. Across Australia, we see that hospitals have large campuses. They have large car parks where a great option for roof-mounted solar systems. And this is a great option for small to medium-sized hospitals. However, larger hospitals need to seek alternatives as well to contribute and sort of make it part of the solution, not just solar panels. The cost and efficiency of solar panels has improved over the last decade, and they're up to 47% efficient, but hopefully this will continue to rise as technology improves. And just to give an example, in the Solomon Islands, where NGO has worked with local architects, they constructed an eye hospital using sustainable materials, and that hospital delivers its power 94% through solar. And another example where it's not necessarily solar panels, but it's more looking at building design. So there's Takeo Eye Hospital in Cambodia, where sustainability was a key factor in their building design. And they looked at how they can make use of the natural ventilation, shade the windows, and have automatic switching lights on and off, basically to keep the temperature down and reduce the use of the power that through fossil fuels. The second case study I want to share with you is looking at the 4 principles of sustainable clinical practice. Firstly, what are those 4 principles? Just to go through them quickly, medical procedures technologies with lower environmental impact is one of them. Leaning eye health service delivery. This is looking at minimizing wasteful resources at health facilities, avoiding duplication, minimizing costs, and that also minimizes patients traveling in, reducing the carbon footprint of that. Increasing patient education and empowerment. This is looking at making the patient less expense on their behalf, less travel needed by patients due to any misunderstandings. And then disease prevention and health promotion. And this is about reducing the use of resources at secondary and tertiary facilities, which tend to have a high impact in the environment, and maximizing care at the primary level facilities. And of course, prevention also reduces that burden of care as well. So looking at using technology, we have this case study where telehealth has been used to provide eye care services. A systematic review published in 2021 reported that telehealth, in fact, does reduce the carbon footprint of healthcare, primarily by reducing the transport associated. And that's very context specific, how far the patient needs to travel. But in their study, it showed that it can go up to 372 kilograms carbon dioxide equivalent, which is a great saving in carbon emissions. In addition to the environmental benefit, there also are the benefits of telehealth. It supports primary healthcare by reducing the burden placed on secondary and tertiary centres. This in turn increases patient access and reduces travel and cost for patients. In this case, telehealth has been deployed across many settings globally, large eye hospitals to small health facilities. And COVID-19 really has catalyzed this, pushing forward, the investments that need to be made to make telehealth possible. So such as setting up systems and pathways, training for the users, and monitoring and maintenance that's required. After the initial investments, there's still benefits that come through from telehealth for people accessing it. And the third case study I want to focus on is around focus your research. So a study that I was involved with a couple of years ago around spectacle distribution. It's a massive problem, particularly in the small Pacific Island nations where spectacles cannot be easily accessed. We have small populations, they don't have the buying power of large countries, and they require frequent transport, shipments coming in for small orders. And we looked at possible solutions to this and looked at solutions such as 3D printing. Could we install a 3D printer and that could make them reduce the carbon footprint for their spectacles distribution? And at the time when we conducted the research, the technology wasn't quite there. The optical clarity required for clear lenses was not available at the time. But I'm thinking this would obviously improve over the years, and that's something we could look at or relook at some alternative solutions around this. Another study that we found was around the review that found there was only 16 studies that looked at the environmental footprint of eye care services, and only one of them that trialed how the intervention actually reduced environmental damage. So there's a lot of gaps in research, and basically the paper went on to say that we need more research. We need assistance in measuring what the impact of the eye care services is we're delivering, and what potential interventions we could be doing that reduces the carbon emissions that are produced. So the underlying message here is that we need to be feeding the pipeline of research now so that we have evidence in the future and we have a good understanding of what different interventions we could be doing to benefit delivery of eye care. And we want to find those hotspots. In other parts of healthcare, they've found gas that's used in hospitals and how that can be reduced. So we want to find those hotspots within eye care and what we can be targeting in the future. And just some lessons from these case studies is that it's not an all or nothing initiative. Every small bit counts. We have combined benefits when we look in the environment. It's not just the environment. We have cost savings, we have improved patient care and improved health outcomes. And we also, with the limited evidence there's still a lot of work that we could be doing. And I just want to also emphasize that although it seems overwhelming, doom and gloom around climate change, we need to be hopeful and keep, chugging along doing the work that we're doing because it is important. And if you wanted to find out more information, please feel free to go to the IPB website, the WHO website. They have lots of resources around this. And you can also join the IPB mailing list to keep abreast of any events and resources that are released. And that's it from me. Thank you.
Thank you. That was very, very interesting. So we're going to have a question and answer session now. If anybody has any questions, please pop them in the chat. But I'd just like to begin by asking Jude, I noticed from your data that women are affected more. Can you provide us any more background on why that is?
Mostly it's related to access or lack of access, and it's disproportionately women and girls have less opportunity to seek eye health services and or get the interventions that they require. This is kind of across the board. When you look at the data, you can also look at the fact that women tend to live longer and eye health diseases are associated with aging. But when you adjust for age standardized prevalence, you still come out with women being that 12% more likely across age brackets to have vision loss due to eye diseases.
I guess that entrenches sort of inequality further.
That's exactly right. It perpetuates the cycle, and especially when we're talking about girls, younger girls who can't then go on to get their education or struggle to get an education and an income or look after their families. So, if a woman loses her sight and her primary job is to care for her family, then that is what also suffers at the same time.
The other group of great concern, of course, is the Indigenous population. And you were mentioning diabetic retinopathy. Is that still a big area of concern for that group?
It is. It is definitely, I think, it's important to note in Australia, I think a lot of progress has been made over the time that I've been in eye health in the Indigenous communities here, but it is still a large issue. It's a large issue in the Pacific Islands in particular. The numbers of diabetes, people with diabetes is enormous and growing, and the people that end up with diabetic retinopathy is disproportionately large because of, again, access to services, and also awareness is a big issue in those communities. And you tend to find that that's a similar trend for minority communities around the world.
Yeah. And then the other thing I thought very interesting was the diagram you had about sustainable goals and how really, vision and eye health impacts on people being able to achieve all those goals. And that really should underpin a lot of new initiatives to try to solve issues with eye health and vision.
That's exactly right. And, when you working at any kind of advocacy level, and governments or hospitals or health professionals have to make choices about where they spend money and where, what's sort of the most cost-effective solutions to hit the most people. And often eye care is down the list because it's not seen to be life-threatening. And whilst it does, poor vision does increase mortality, which I pointed out, it's also the linkages to the economic case and the loss of productivity for an individual, a loss of productivity for an organization, a loss of productivity for a global economy actually changes the way people think, because then the investment in eye health becomes worthwhile. The WHO, get the numbers right, but the investment is actually, the return on investment in eye health is starting to be shown to be very affordable, and it really can make a difference to the bottom line. A study was released from India in the last few weeks, showing that if you invest in eye health, the GDP of India will grow, basically, and that's it changes the way it's viewed and thought about. And there's also sort of health economics being done, particularly around children, and investing early to address eye health issues to prevent vision loss. And make sure they have good eye health really will change the economy in the future as well. So it's a different angle, and being part of the UN has opened up a lot of opportunities now to embed eye health more broadly and to look and invest in solutions, particularly in technologies, because of the enormous burden it would have, eye health already has on the workforce, and meeting the need without technology would be almost impossible.
Thank you. And Mitasha, spectacles is something we really take for granted. Looking around the panelists here, we all have access to spectacles. it's interesting that such a sort of a simple solution is unfortunately not available to many people across the globe. And, you know, there was a good case study you presented there on technology. Do you comment any further on that?
Yeah, so as you mentioned, spectacle access is very, I guess, different depending on where you are in the world. Obviously, if you're in an urban area like Sydney, it's very easy to access, but it's still quite unaffordable for a lot of people. You've seen the markup on glasses, a few $100s, and if you go overseas, sometimes it's $20. So there's a lot of discrepancies around the affordability as well around spectacles. But the case study that I presented was particularly around the Pacific Island nations, where it's not even the point of affordability yet, it's about access. So they don't have manufacturers locally. Most of the manufacturers are in big countries like China, and shipments from China, you know, to buy it for a small population, you have the purchasing power is also not there. So we really wanted to look at what solutions there were. We've tried, you know, over the years, donor glasses, which obviously is not very acceptable at the moment because it's, you know, it's not a sustainable solution. And we also trialed small social enterprise models as well. So we're trialing all these different models, but basically we want to make it sustainable at the same time. So we want there to be a minimal carbon footprint as well. So even if we send glasses from here, if someone is, you know, can fund it and all of that stuff, it's still, you know, the shipment to each island nation, and they're very hard to also reach as well, these island nations. They're very sparse and spread out through the Pacific Ocean. So it's just looking at different models. And unfortunately, at the time when we looked at the technology, it wasn't quite there yet. We were inspired by, there was a presentation around, you know, blood vessels being 3D printed. So why not glasses? Why can't we do spectacles? But yeah, it's the lens, the frame was fine to, I guess, produce through 3D printing, but it was the optical quality of the lenses. It had to, you know, for you to be able to see through a plastic lens clearly at the right power, it needs a certain level of technology for that. But I'm hopeful that that might come through in the next few years or decade, hopefully.
And I guess the other thing that struck me listening to the talk is that, you know, we do have some solutions to treat big problems like cataract, but they're not really very sustainable. It's almost like we need to go back and look at everything we're doing and use technology to reimagine things in a better way for the future.
Yeah, and like you saw the example between the cataract surgery done in India versus cataract surgery done in UK. And technology can be very simple. Like the intervention can be very simple, but at the same time, it can produce such great results. So in India, they've honed down on their policies and procedures around how they carry out the operation. I don't know the exact details on me, but basically, you know, they're recycling, they have color-coded bins within the operating theatre, so that basically straight away from the start, everything's sorted and put in the right system to be processed. So that generates less waste. They, you know, do certain things where they make sure the patient safety is still up to a high standard, but the sustainability element is also considered.
I think that concept that you said is definitely about thinking differently, and you know, taking for granted so many technologies that are fantastic, but could possibly be bettered with what we know now and what is capable in different areas that didn't exist before.
Yeah. Well, thank you very much. So that brings to a close the session on the global perspective. And now we're going to move to something a bit closer to home, Australia and the university perspective. And I'm pleased to introduce Professor Peter McCluskey, who's an internationally recognised inflammatory eye disease specialist with more than 30 years experience at treating patients with vision-threatening inflammatory eye disease. And he runs the largest tertiary referral public sector uveitis service in Australia at the Sydney Eye Hospital, and is involved in clinical research, lab research and clinical trials, and he's head of the Save Sight Institute. Thank you very much, Peter.
Great. Thanks very much, Stephanie. It's a pleasure to be here. And I'd like to begin by also acknowledging the traditional owners of the land that we're on, and pay my respects to Aboriginal leaders past, present and emerging. And I'm speaking from the land of the Gadigal people of the Aurora Nation. I don't have any relevant financial disclosures. And what Stephanie asked me to talk about today was, because it's a broad audience, I just thought I should review some of the basic features of eye anatomy, talk to you about how we assess eye disease and some of the technology that we use, and then show you some of the common causes of blindness in Australia that follows on really very nicely from the talks that Mitasha and Jude have given, and then show you what sort of research our researchers are going to talk about in the remainder of the session. So just to remind you, we tend to divide the eye into two halves. There's the anterior segment, which contains the cornea, the iris and pupil, and the crystalline lens. The cornea and the lens are the major refractive components of the eye. So they bend light rays so that they focus on the back surface of the eye, which is the retina, which then transforms the light into electrical impulses. So corneal disease causes corneal blindness. When the lens becomes opaque, that's a cataract. When this little drain that's in the angle between the cornea and the iris becomes damaged, and that's it in this sort of cartoon here, that's the major area or damage that leads to glaucoma. And then there are also a lot of important diseases that involve the retina. So when someone has corneal disease or a cataract or glaucoma, how do we sort out what's going on? Well, the good thing is that we can actually see the cornea and see the lens in our eye. So with this slit lamp biomicroscope, so it's a microscope that's been turned around so that we can use it to examine the eye, we can get most of the information that we need, and obviously we take a history from the patient and talk to them. We can assess the structure of the anterior segment of the eye now very precisely with sophisticated instruments like this pentacam that allow us to draw contour maps and measure the thickness very accurately of the shape of the surface and the thickness of the structure of the cornea. We can also get high quality cross-sectional images of the anterior segment of the eye. You can see the cornea, the iris, and the crystalline lens here. And obviously we assess function in anterior segment disease by checking the visual acuity. So as I mentioned, the retina is the part of the eye that transforms light impulses into neural signals that then exit the eye through the optic disc to become the optic nerve and go off to the brain, which actually interprets them and does the seeing. But the important area that I wanted to talk to you about was just to show you that in the center of our retina is this area called the macula, where the normal retinal anatomy has been altered slightly. And this change in the anatomy here is what gives us our high acuity, sharp vision that allows us to read, to recognize people, and make us superior sort of hunters and gatherers, and at the top of the food chain on Earth. And this is a common focus for eye diseases such as macular degeneration and diabetes. So we've really sort of improved our ability to investigate retinal diseases an extraordinary amount over the past 40 years. When I began as an eye doctor, we really had clinical assessment. We could measure visual acuity, and we had this fairly primitive instrument called the direct ophthalmoscope that allowed us to look at the retina. But now we have this enormous range of imaging studies that allow us to assess the structure of the eye in great detail, and I'll show you some of these in a moment. We also assess the function of the retina by measuring visual acuity, looking at things like color vision, the extent of the person's visual field. And we can also now, with very sophisticated recording equipment, look at the electrical responses of the retina, the optic nerve, and the visual cortex. And these sort of modalities have really changed the way we look after patients with eye disease. So the first big step was we've now got really good digital cameras. That image of the retina that I showed you before fits inside this red circle. There's the optic disc and the macula. But the retina, in fact, extends a long way out. It's a sort of a hemispheric sort of structure. And we now have these things called Optos wide field cameras that will allow us to get an image of the entire retina in one sort of frame. And we can manipulate these images electronically to learn a great deal. We can also illuminate the retina with different colored lights, such as blue light and green light and infrared light, and look at the sort of fluorescence patterns that the various structures in the retina and the layer underneath called the retinal pigment epithelium have. And that is really useful at analyzing different diseases. We can also use these cameras to take images of the eye after we inject dyes, such as sodium fluorescein, which allows us to image the retinal circulation in great detail. If we use a dye called indocyanin green, we can image the choroidal circulation and look for disease in that circulation. But the thing that's really changed how we look after eye disease is this technology called OCT, Optical Coherence Tomography, which uses diffraction and reflectance technology. And we illuminate the retina here with infrared laser light. And that allows us to get these extraordinary detailed cross-sectional images of the macula. And this is where the macular anatomy has changed. That here's a cross-section of the histology of the retina, and it's 10 layers thick. But in the macula, most of those layers are peeled back so that light can shine directly down here onto the photoreceptors. And that's the sort of evolutionary change that's given us our high acuity vision. But now with technology, we can get almost a sort of a pseudo histological cross-section of the retina. It took 10 years for us all to agree on what the black and white lines were, but now that we know what they are, they've really revolutionized how we look after retinal and in particular macular disease. And this sort of collage just shows you that we can see swelling, what we call edema, cystoid macular edema in the retina. We can see masses in the choroid, the blood vessel layer under the retina. We can see inflammation. Here's toxoplasmosis infection. Syphilis affects a particular layer in the eye. Other inflammatory diseases cause other quite typical pathological changes. And because this technology is painless, non-invasive, we can do the scans in a couple of minutes. It gives you objective data. It's readily repeatable. It's really now, when this technology is available, the way that we look after most retinal disease. And as was highlighted by Jude and Mitasha, accessing this expensive technology in much of the world is still a dream. But if we look at Australia, eye disease and blinding eye disease is a major problem. There's over 500,000 patients in Australian citizens who are blind or have severe vision impairment. We know that's going to double over the next 8 years. We know that there's 3 times as many patients, at least in Australia, who've got some form of vision impairment but aren't blind. And it's extremely expensive to our community and to our economy. And that's one of the reasons that the University of Sydney has made the SafeSight Institute a flagship research enterprise in our faculty, because it recognises how important eye disease is. So this is repeating a little bit of some of the material that Jude and Mitasha spoke about, but I just want to show you some of the common causes of eye disease in Australia and how we look after them. The important thing to focus on is that more than 80% of blindness in this list is perfectly treatable and largely preventable. And if you look at the disease for which we have no treatment, it's these things called IRDs, inherited retinal diseases. So these are genetically determined diseases. And now, just in the last couple of years, we've started to get gene therapies that can treat these untreatable diseases. But if you look at the common causes of blindness in our country, it's the same sort of suspects: cataract, uncorrected refractive error, glaucoma and corneal disease, and then these retinal diseases: age-related macular degeneration, diabetes, and inherited retinal diseases. And I'll talk to you briefly about each of these and how we look after them. So before I do that, just to reinforce, if these are the sort of common causes of blindness in our community, and the x-axis here is age, and you can see in each of them, they get commoner as we get older. And if you can't see when you get older, your quality of life is miserable. You can't drive, you lose your independence, you can't read, you can't look after yourself, you can't recognize people. And this leads to many consequences on our health. Triples the risk of a hip fracture and falls, it triples your risk of becoming depressed, doubles the amount of healthcare resources that you use, and more than doubles your risk of dying prematurely. So treating blindness and vision impairment has major consequences on the patient individually and on our community. And the commonest cause in our community is cataract. And by the time you get to your 90s, 15 to 20% of us have got visually significant cataract. As I mentioned earlier, these diseases are very, very expensive. And this just focuses in on macular degeneration and diabetes. But you can see the direct costs alone are $7.2 billion, 10 or 12, nearly 15 years ago now. And when you add in all the indirect costs on the family and loss of productivity, etc., these are very serious amounts of money that these diseases are costing us. The good thing is that many of them are eminently treatable. As was mentioned earlier, cataract is easily treatable now with a highly precise microsurgical procedure where we liquidize the lens and remove it through very small incisions, and then we replace the crystalline lens that's gone cloudy with a replacement intraocular lens, which we can roll up and insert through a 2.5 millimeter incision. This is day surgery done under local anesthetic, very short recovery time, very low risk of complications. So has transformed the commonest cause of blindness in the world that we can treat. I'm still staggered that in a country like Australia that's wealthy and has a really good health service, that the second commonest cause of vision impairment in our community is uncorrected refractive error that we could easily fix with glasses. I mean, there are literally thousands of optometrists in Australia, yet still there is a significant proportion of our population who either have limited access or can't afford spectacles so that they can see. We've got to fix this problem. Around the world and also in Australia, corneal blindness remains a very common cause of irreversible vision loss. It's a priority in the World Health Organization. In a country like Australia, it's usually the commonest cause is from infection, say in people who wear contact lenses or following trauma. And corneal blindness is often irreversible, can affect young children, which is just tragic and is a major sort of problem. The other important disease that involves the anterior segment of the eye is glaucoma, which is often called the sneak thief of sight because it's asymptomatic until the patients have lost the majority of their visual field. So by the time a patient comes in and says, I'm not seeing very well, if they've got glaucoma, the horse has already bolted. Age and a positive family history are the two important risk factors. There are also ethnic risk factors. Patients who are ethnically Chinese and East Asian have a higher risk of glaucoma than some other populations. There are a number of different mechanisms. It can be a very difficult disease to treat, particularly if it's advanced. This is a normal optic disc, and when the pressure in the eye becomes elevated from glaucoma, it slowly but surely chews away at this pink healthy rim of nerves, and the optic disc just atrophies and you lose all the nerve fibers and then you go blind. But the other major group of diseases that I want to focus on are these macular diseases. And age-related macular degeneration is a very common disease in our community. As you can see, 1.3 million patients at the moment have some form of macular degeneration, and it's just going to increase because, again, the major risk factor is age, and as we pointed out, climate change, UV exposure, smoking, poor diet, a whole range of environmental factors that we can influence. So the sign that we see are these funny little areas that start to accumulate under the retina called drusen, which we can see here on one of those OCT cross-sectional scans. What these drusen represent the inability of the eye to deal with waste products from the rods and cones, which are the photoreceptors. And what happens in about 80% of people who get macular degeneration is that the macular region basically just wears out. And the little rods and cones, which are this layer here in the retina, just disappear, and the patient just slowly loses their central vision. But in about 20% of patients, what happens is where these drusen are, an area of damage occurs in the membrane that separates the retina from the choroid, and an abnormal blood vessel grows in from the choroid into the retina. And here is one outlined of a fluorescein angiogram. And this abnormal blood vessel leaks and causes fluid to accumulate and eventually bleeds, which then causes a massive scar in the center of the retina in the macular region. And this patient has catastrophic central vision loss that's permanent. The other disease that causes a lot of macular damage and blindness in our community is diabetes. We're in the middle of an epidemic of diabetes, not only in Australia, but around the world. The prevalence of diabetes has tripled in the last 20 years and is continuing to increase. In some parts of Sydney, over 30% of the population has diabetes. And the other big problem is that half the diabetics in our country remain undiagnosed. And what happens is that the diabetes damages the little blood vessels in the retina so that they start to bleed and leak, again, causing swelling and waterlogging of the macula. In some other patients, the damage to the retinal blood vessels becomes so severe and widespread that the retina thinks it's not getting enough blood supply, so it starts to grow new abnormal blood vessels from the optic disc, like these ones here and these scarred ones here. And this is called proliferative diabetic retinopathy. And these again bleed. And people with this form of diabetic retinopathy, 50% of them are blind within 18 months, and the majority of them blind within 3 years. This is largely 95% plus of this type of vision impairment is completely preventable with early detection and treatment. We know that both macular degeneration and diabetic retinopathy are driven by a hormone that's made in the retina called VEGF, vascular endothelial growth factor. And over the last 20 years, we've developed a number of drugs that are very effective at binding to VEGF. They're basically monoclonal antibodies or bits of them. And if you suck up all the VEGF that's in someone's retina by injecting directly into the vitreous, the center of the eye, these antibodies, you will stop and reverse that abnormal blood vessel growth and stop these patients from going blind. The problem is that these drugs are expensive. A single dose of these drugs costs about $1,400. The patients need these injections monthly, often for life. And so it's an intensive, invasive, and very expensive treatment. And this drug, aflibercept and ranibizumab, which are the two main drugs we use to treat macular degeneration and diabetic eye disease, as you can see, they're firmly entrenched in the top 10 drugs by cost to the government and cost well over $500 million in the health budget last year. And aflibercept is the most expensive drug by cost in the PBS. Because this is expensive, there are out-of-pocket costs if patients don't go to one of the few public sector clinics. And it's so intensive, and these are old people who often have comorbidities and poor mobility. We know that over a quarter stop treatment within a year, nearly 50% by 2 years, and sadly untreated, the vast majority of those patients become blind within 3 years. So just as Jude and Mitasha were saying, sorting out these blinding eye diseases is a topic of great interest for government, for our eye college, for Vision 2020, for IAPB, for many, many organisations, NGOs, governments, WHO. There's a huge unmet need, an enormous inequity of access. So this is a huge problem that is, if we all put our sort of shoulders to the grindstone, is largely fixable and treatable. So I guess coming back to where does the Safe Site fit in? Well, as a flagship centre, we've been recognised for our excellence in research. Hopefully we're going to get some more funding from the university. We are strongly aligned with the sort of research performance and high sort of tech research that the university is engaged in. We have research groups in SSI that focus on retinal and macular disease, on corneal disease, on inherited retinal disease, and other common important causes of blindness in our community. We have a broad range of research groups, but in this sort of symposium, we're really going to talk predominantly about nanoparticle drug delivery in the retina and in the cornea. So that's hopefully just given you a framework for particularly those of you that aren't sort of ophthalmologists or heavily involved in the eye sort of sector, the background and the flavour of the diseases that we look after, the tools that we've got to assess them, and the drugs that we have to treat them. And I'm going to hand over to our three research scientists who are going to sort of give us their sort of perspective on research. Thanks very much, Stephanie, and thanks for listening.
Thanks, Peter. Before we hand over, we might just see if anyone's got any questions for you that they can pop into the chat. And while we're waiting for that, I thought it was very interesting with OCT and the advances that have been made. And I recall that it's actually delivered over 2,000% return on investment for taxpayers' money in the US. And has saved over $9 billion in Medicare costs in the US alone. So these sort of technologies really can be quite transformative. And imaging is another area where we need technology. So we need technology to treat conditions better, but we also need technology to diagnose conditions. And for the future, it would be good to have these pieces of diagnostic equipment available for more, because they are quite expensive. I noticed Ben in the chat that it was invented, OCT was invented by an MIT professor. So, yeah. So it is an area I think we need to work on it. Any comments there?
Yeah, well, look, I think you know, digital technology is hopefully going to help us in miniaturizing these things. Already, you know, we can take similar digital images with an iPhone to those that I showed you. And that's going to make things really much more accessible for people who don't have good access to eye care. There are primitive versions of OCTs that can be done now with an iPhone. And that's really going to be the way forward, particularly, you know, in the Southwest Pacific and in rural and remote communities. The other big thing is going to be telehealth. You know, I run outreach clinics. I know it sounds ridiculous, Darwin and Hobart, they're not really rural and remote communities, but I can do my eye clinic in Hobart from Sydney if I need to. And I've done that for the past 2 years because of telehealth and having the technology down there. So I think we have a real opportunity to be able to bring our sophisticated technology to rural and remote communities using things like what's the name, the iBus that can go out to a remote community, and then everybody can get their scans. It can go to a remote reading center where we can then work out a management plan. So yeah, we've got to get that technology out into our community to work particularly on inequity of access. Ben.
Ben,
Yeah.
do you have a question?
Yeah, or comment. I love this session, by the way, it's fantastic. But I particularly resonate with the OCT example because I followed that throughout my career, and I'm familiar with the researcher at MIT, James Fujimoto, who invented that, and it had a huge impact. And it's based on an ultra-fast laser. So it is really placed to my background. And for decades, we've heard talk about how that could be miniaturized and made more ubiquitous. So the notion that it could be integrated into the smartphone is just fascinating. And I'm wondering, Peter, where is that up to? Because I guess what's missing for me, it relies on quite a complicated laser system that may not lend itself to integration into a phone. And is that something, or is there an alternative approach that they're taking there? You know how that works?
No, look, it's not. I just know people are working on being able to miniaturize it and change it, so that it can be used or somehow adapted so that there'll be much smaller OCT that we can then upload the images from. But it's not an area I'm completely familiar with. But certainly I am aware through people like Greg Swining and stuff that people are working on this sort of technology.
Yeah, worth noting, there's good expertise in the University of Sydney in laser physics in that area. So there could be some follow-up opportunities to understand what that roadmap looks like.
Yeah. But, I can't really, well, I could, but I prefer not to practice without an OCT. It's extraordinary technology. Of course, it's not reimbursed in Medicare. So every scan is either subsidized by the ophthalmologist or has to be paid for by the patient.
So the ophthalmologists have OCT. Do the optometrists have OCT?
Many optometrists have OCTs, yeah. And most optometrists now have an OCT and an Optos camera. And so they can take these images and then they, send them to us and we can help to triage what's going on. But digital technology is rapidly revolutionizing, ophthalmology.
Yes, my only other comment on OCTs and imaging is it's a structural assessment, and what we also want to do is integrate function, and there could be new sensing technologies that we're not currently using that could provide us with more information on how the eye functions, and that's particularly in relation to the cornea as well, to understand how changes of shape occur. But we have a question in the Q&A. Just somebody's wondering about what the impact of discontinuing Avastin in the public system would be.
Yeah. Well, that's. I think there's two approaches. First of all, the pharmaceutical companies have come up with some very generous ways to support our community during this. And the second thing is that there are a rapidly increasing number of biosimilars for Avastin, and biosimilars are currently undergoing early trials in different parts of Australia, and it's likely that biosimilars will be the answer for the shortage of Avastin. The other thing that we've done for Avastin is through the College of Ophthalmologists, we can become approved providers, and it can be imported from other countries where it's still available. Basically, just for background, the Roche, the company that manufactures and distributes Avastin around the world, has selectively withdrawn Avastin from some markets, notably the United States, Europe, the UK, and Australia, for reasons that are known only to them.
Well, thank you, Peter. That has been that's been great. It's really added to our understanding of the issues that we're facing here in Australia and also globally, and some of the solutions that have already come to light, but where we also need to go in the future. So I'd now like to move on to some research perspectives on eye health and nanotechnology. And the first speaker we have today is Ling Zhu. Dr. Ling Zhu joined the Macular Research Group at the SafeSight Institute to continue his career at the interface of clinical and basic research. He's now the head of the lab there, leading 1 postdoc, 2 research assistants, and 1 HDR student. Thank you, Ling.
Thank you, Stephanie. Thank you for giving me this opportunity to talk about NanoVision project. This NanoVision project was partially supported by the Kickstart grant from the Nano Institute in 2019. Today, my presentation's topic is the development of human retinal cell-specific RNA lipid nanoparticle drugs to treat macular degenerations. The blindness from the retinal diseases, such as age-related macular degenerations, inherited retinal diseases, and diabetic retinopathy, has vast physical and psychological impact on patients, their families, and economic. The figures now show the same view with different retinal degeneration diseases. Current treatment for many retinal diseases are ineffective. New frontier clinical solutions for retinal diseases are urgently needed. Scientists have identified hundreds of retinal disease-related genes, yet few have been translated into treatments. We believe the real-world applications of gene therapy will remain limited until we have a practical, safe, and effective method of delivering therapeutic payloads where they are needed within the human eyes. Nanomedicine has been identified as a dominant and most commercially invented technology that aims to improve the quality of healthcare strategies. Although the nanotechnology still has some limitations, many pharmaceutical companies have already adhered to nanomedicine. In some cases, drugs with high toxic potentials, such as chemotherapy cancer drugs, can be administered with a better safety profile using nanotechnologies. Lipid nanoparticles offer the potential to revolutionize therapeutic payloads delivered due to the ability to pack and deliver large array of therapeutic molecules. Structure diversity across the lipid nanoparticles confers various affinities to different cell types, thereby permitting specific targeting of retinal cells that express the defected genes. The overarching goals for our research program is to establish a high throughput systems on human retinal-based research platforms to develop retinal-specific lipid nanoparticles as carrier for retinal gene therapy. To achieve these goals, we are focusing on the following 4 directions. First is advanced human retinal explant culture systems. Second is a robust in vitro transcription systems. The third is a microfluidic system to synthesize lipid nanocarriers. And fourth is a novel treatment target for retinal diseases. So scientists have established many disease models in cell culture systems and animals. Most therapeutic candidates are screened through these laboratory models, which has substantially different molecular biology, anatomy, and physiology from humans. Results obtained from these preclinical models of the retinal diseases, therefore, may not be replicated in humans. This table shows the detailed difference between human and the different model systems. For example, the mice do not have macula, which is responsible for sharp central vision as humans do. Most cell culture systems cannot mimic 3D complex organs and tissues. Furthermore, the laboratory animals has been developed as inbreed strain with highly homogeneous genetic compositions to increase reproductivity of the results and the statistic powers of experiments. Clinical features often vary different animal strengths. Such difference between animal models and humans may widen the gap between the laboratory research and clinical trials. We have established an ex vivo human retina culture systems that may be a way to narrow the translational gap. It can keep the intact structure of the human macula so that we may study it as a whole. Our most advanced human retina explant 2.0 vision can even mimic blood flows and the human microenvironment. It will preserve cell-to-cell interactions within the macula and mimic in situ response more precisely. We also established a robust in vitro transcription system. The figure shows a functional mRNA consisting of a 5' cap and a 3' poly A tail, which are used to stabilize this mRNA. Also, a 5' UTR and a 3' UTR can stabilize this RNA and regulate the translational efficiency. The central coding region is our gene of interest. The gene of the interest region can be easily replaced by different DNA sequence to adopt any new therapeutic target within weeks. Our lipid nanoparticle was synthesized in the microfluidic systems from the Sydney Pharmacy School. In the figure A, the left is schematic illustrations, and the right is a picture taken while fabricating the lipid nanoparticles. The lipids were dissolved in the ethanol phase, and in the acryl phase is the RNA dissolved in a citric buffer. At the interface, which is a gray area in the lipid nanoparticle contained RNA were formed. In the figure B is a schematic illustration of the lipid nanoparticle structures we synthesized by us. And C is the AFM image that shows the three-dimensional topographic image of the lipid nanoparticle surface. In the figure D, the three curves stand for the size distribution of the same lipid nanoparticles at different time points on day 0, day 7, and 3 months later. If we merge the size distribution curves of the same samples, we can see they are pretty identical to each other, which means they are very stable. They do not change after several months, which means they can be transferred easily worldwide. In the past 10 years, the Macular Research Group has identified several genes targets that may have a potential to treat retinal degenerations. All of these targets are specifically expressed in certain retinal cell type. So it is very important for us to deliver the gene therapy cargoes to target certain cell types. We believe we may achieve this goal with the help of the certain formulations of lipid nanoparticles. One of our major ongoing work now is the preclinical studies of putting different mRNAs of these targets into the different formulations of lipid nanoparticles and test the therapeutic efficiency ex vivo and in vivo. So this research program was guided by the research director of the Safe Site Institute, Professor Mark Gillis. Our collaborators, Professor Wojciech Jaworski from the pharmaceutical school, gave us tremendous support for the lipid nanoparticle synthesis. This project was also supported by the international collaborations from Zhejiang University and West Virginia universities. We also want to thank the eye donors and their families for the human donor eye tissues used in this project. Thank you.
Thank you very much, Ling. Another great talk. We're going to do questions at the end of this session. So if anybody has any questions, they can pop them in the chat. And now I'd like to introduce Dr. Yogi Ramoswami, who is a chemical engineer with a master's degree in biotechnology from the University of Queensland and was awarded a PhD in biomedical engineering from the University of Sydney in 2009. Thank you, Yogi.
Thank you, Stephanie, and thank you, Sydney Nano, for this opportunity. I'll just share my screen. Yeah, so today would like to discuss about some research perspectives of using bioengineering and nanotechnology to advance the solutions for ocular tissue. So to highlight here, there is an imbalance in organ transplantation, as you can see here. And there is emphasis on developing new technologies to overcome the problems with these organ transplantation from different perspectives. So if you look at the global healthcare here, there is a significant surge in the regenerative medicine market. And this can be broken down into the technologies that can be used, such as developing biomaterials, tissue engineering approaches, and stem cells or cell-based therapies. And we can identify different tissues or for using such technologies to overcome the problems related to them. And we can merge engineering principles and cell biology and work towards restoring and repairing damaged tissues. And the crux here is using biomaterials, cell sources that is relevant to a particular tissue, or the proteins and the nanoparticles to provide that niche environment. And this becomes the most important elements to look into repairing damaged tissue, including for ocular applications. Now, a different type of materials can be explored based on the applications that you're targeting. And I've been involved in developing some of these materials. So I got interested in this field through my master's and my PhD program, where I was pretty much focusing on developing these materials for orthopedic applications to look into the defect in the bone or the repair of the broken bones, which led to exploring more about these kind of materials and cell material interactions, including the stem cells or endothelial cells and the primary cells, which eventually has led to many other groups evaluating this material and also looking into large animal models as well. Now, apart from these ceramic-based materials, I'm more interested in looking at biopolymers, which is more relevant to what we're discussing today. And a different type of polymers I'm working on different type of these polymers, which is from synthetic ones, or it can be naturally derived ones. And these polymers can be functionalized depending on the applications or the tissue you're targeting. So at the moment, there are different projects in the groups, and we're looking at using these polymer-based platforms to understand various aspects, including looking at how mechanics have a role in tumor microenvironment. And these platforms are quite, is very suitable to look into these aspects. And that's when I came across Stephanie in one of the Sydney Nano meetings, and we started discussing about how these can be involved for ocular applications, which she was interested in as well. And if you look at the cornea itself, or in case of a healthy eye, you can see a healthy limbus. There is a transparent and clear cornea and conjunctiva. And when this is damaged, which could be because of trauma, that could be chemical or induced by chemical or thermal burns, radiation, drug induced. And these are quite prevalent situations in societies where safety standards are quite compromised, and also in keratoconus, which is now many of the groups are looking into how this can be addressed as well, where there is distortion in the cornea. So in case of limbal stem cell deficiency, where it requires the stem cells over there, and even in case of a partial deficiency, you can see that the conjunctiva is partially overlapping the cornea. And when there is a full total deficiency of these limbal stem cells, then the entire corneal surface is completely covered by this conjunctiva, and a vascularization takes place. So, under these conditions, the regenerative capacity of the corneal stem cells is damaged and can lead to visual impairment. So these strategies of using the polymer-based materials that we are developing and integrating with cells and proteins or nanoparticles can address some of these problems that is due to the impairment of these regenerative capability of these cells, and then focus towards repairing or the damaged tissues. So now looking at these polymers, so we can make hydrogel out of it, which is basically a highly swollen polymer network with high water content. And they can, as I said before, we are developing in our lab the natural and synthetic polymers, and they have similarity to soft tissues. And that's why these kind of materials are looked into for contact lenses or other soft tissue applications, including the eye. So in my lab, we have looked at building these, using these polymer materials, and then you can 3D print it, because this can give you a control on the architecture, structural versatility as well. So students have developed a custom built 3D printer, because we can have a better control on the way we look into the resolution of these filaments that is being printed. And we could encapsulate stem cells, adipose-derived stem cells, and look into their functionality as well. So here, in case of commercial bioprinters, the resolution was about 100 micron. And with our printers, we could go down to about 8 to 20 microns, and at the same time encapsulate the cells and looking into their functionality in this 3D environment where these with controlled filaments. And this becomes quite relevant in our studies, because we can also control different architectures and using these polymers as inks. So this could be applicable in a regenerative medicine sector, and especially when we're looking at stem cell therapies for ocular regeneration, for corneal regeneration, which can, and also cornea can be an ideal model to develop these kind of stem cell therapies, because the similar models can then be recapitulated into addressing problems with the other tissues as well. So Stephanie has looked into this aspect, but she's used the contact lenses as the scaffold and used the limbal biopsy, where she could use the contact lens as a scaffold, and these can expand the cells. And this can then be delivered onto the eye and look into the regenerative capabilities. And this was done in the patients. However, there is still more chance to improve the stemness of these cells and the number of the cells. And we can use these new materials that we are developing in the lab to look into whether these can help in increasing the stemness, stem cells, numbers as well, which becomes quite relevant to treat these kind of damaged because of the limbal stem cell deficiencies. So what we looked at here is we're using hydrogels. We're basically looking at the FDA approved polymer materials, and then integrating with multifunctional nanoparticles, along with the ability to deliver the related protein integration. We've identified the proteins that can help in increasing the number of cells and scaling it up, and looking at their stemness capabilities as well. So we're targeting the FDA approved materials here with an intention that this can go into commercial benefits later. and working with other research institutes, CSIRO, and other bodies which can really encourage in this kind of research. So at the moment, with the support from Sydney Nano Kickstarter grant, we have looked into these, actually making these hydrogels. We functionalized this polymer and fabricated these gels and integrated them with some naturally derived nanoparticles that we have identified and controlled the size and looked at the dose dependency of their relevance to for stem cell applications that can increase. And we can control the stiffness of the gels to see whether the physical environment integrated with these nanoparticles that can deliver these proteins can really increase the stem cell numbers and the functionalities. So we are working on this, and we need to look a bit more into the proteins and their delivery patterns and in a controlled way, and how that is eventually affecting the stem cell growth when in this microenvironment. So we really have brought here a very multidisciplinary team where we can contribute in nanobioengineered platforms. We have a clinician and biologist engaged where they can attribute towards biological stem cell biology and some of the in vivo models, and working with industry partners, investors, and philanthropists to support this research, which could change the lives of many people who have undergone accidents with chemicals or burns and change their lives. So looking at not only the fundamental discoveries that could come up with this technology, looking at the cure and improving indigenous health and chronic disease costs, and also targeting some of the developing countries where really the safety standards are compromised and the chances of accidents occurring is quite large, as we can see in compared to what we can see in advanced countries. And this could, and targeting FDA approved materials so that we could look into the clinical translation of this work. And next generation experts can be trained from a multidisciplinary spectrum. So basically what we looked here is biofunctionalize the materials to enhance these biological responses, designing and engineering biopolymers and using analytical tools for these kind of targeted therapeutics, and redefining the approach of developing the solutions for various biomedical applications, including ocular diseases, where we can move away from using the contact lenses, and it can give a much more control on the materials that we're using. So I'd like to thank Sydney Nano and the Kickstarter grant and my students and the other funding body who support my research.
Thank you very much, Yogi. That was excellent too. So we've heard a lot about blinding diseases, but there's other conditions that can affect the eye that do impose a great burden and are increasing as we have globally changing environments. And one of those is dry eye, which can affect up to 1 in 5 people. And the burden can be as severe as angina. So to talk about dry eye, we have Dr. Ken Uy, who's a consultant general ophthalmologist and cataract surgeon with an interest in ocular surface and ocular inflammation, including dry eye. And he's a senior lecturer at the SAVE site. Thank you, Ken.
Thanks, Stephanie, and all for including me. I'm just going to try and share my screen. And this should come up. Is that okay?
Yes, thank you.
Thank you. Thank you. Well, I'll be talking about nanotechnology and its application potentially for dry eye within our SAVE Site Institute. Specifically, I'll be talking about the relevance of nanotechnology as applied to topical atorvastatin in eye drop form as a novel dry eye treatment. Atorvastatin, as a lot of you would know, is actually Lipitor, a cholesterol-lowering drug used in cardiovascular disease. I'll get onto how the transition has been made in due course. So as Stephanie says, this is quite a burden to society, and with reduced work productivity, blurred vision, pain, discomfort, watering, this can really impact on people's lives on a day-to-day basis. There are very few treatments at the moment, and a lot of these are with limited efficacy and also a lot of side effects. There are only currently 4 drugs in Australia which address only some elements of dry eye. Artificial tears still remain a mainstay of treatment, and there is really still an unmet need for treatment of root causation for dry eye. There are a number of causes of dry eye, and I'll be looking mainly at the evaporative causes for dry eye, specifically looking at blepharitis, the major cause of evaporative dry eye. So just going through some of the basics, this is what I tell patients in terms of explaining dry eye. I say to patients, you know, we know tears are salty. The salt water from the tears comes from the lacrimal gland, which is situated behind the brow bone. And this is kept on the eye by an oil layer, a lipid layer, which helps trap the salt water by the principle oil and water don't mix. This oil layer comes from the meibomian glands, which are situated here in the eyelid. And when there is a disease of this meibomian gland, it is blepharitis, and the oil glands are blocked off by an oil secretion, which normally would be liquid, but is now too thick. It's too thick because there's too much cholesterol within the oils of the meibomian gland, and it can be related to systemic hypercholesterolemia. So when you have a dry eye, when there's not enough salt water trapped on the eye by a poor oil layer, then the eye gets inflamed. I equate it to dry skin for patients. So if your skin is dry, it looks red and it's inflamed. The same can be said for the ocular surface when the eye is dry. There is inflammation as well to the ocular surface. So when I think of the atorvastatin Lipitor, I say it in terms of this to people that it's used for lowering cholesterol. And a lot of it is also due in terms of its impact on cardio-morbidity and mortality reduction is the fact that it's inflammatory lowering as well. It helps to stabilize plaque in coronary artery disease to stop clotting. So what we've done is we've taken atorvastatin, which is now off patent, and made it into a dry eye drop. The patent is for it as a novel tear film stabilizer. So the preface is that basically we are saying that the topical statin, which inhibits HMG-CoA reductase, can actually block cholesterol synthesis or the oversynthesis of cholesterol in meibomian gland dysfunction. This then therefore leads to a stabilization of the tear film through correction of the lipid layer, bringing the lipid layer back to its baseline. Now, as I mentioned, atorvastatin also is inflammatory reducing, and these are through its pleiotropic actions. They reduce a number of anti-inflammatory cytokines. So our intellectual property covers evaporative dry eye and blepharitis, and it's patent now in a number of countries, but is still awaiting clearance of amendments in the US. So this has come about because of a pilot study that we did with 10 patients treated with topical atorvastatin at 50 microns at 8 times a day for a period of 4 weeks. And we showed some excellent results with respect to reducing dry eye signs and symptoms. So essentially, to make it simple, where you have quite severe staining dry eye here with fluorescein, showing dry eye patches galore, giving the topical atorvastatin in eye drop form helps to reduce this. And here we can see now clear cornea. Severe dry eye like this can lead to corneal blindness. Just to go into a little bit more detail, one of the most remarkable things that we saw from this, and I wish we had video capture for it, was the increase in tear breakup time. So normally the tears should stay on the eyes for about 10 seconds. And here we see all the patients at the beginning of the study where the tear breakup times were very low. And it can be seen here that the tear breakup times did increase quite remarkably. I had one patient sitting in front of me on the slit lamp, and their tear breakup time was 90 seconds. So they could basically keep their eye open for 90 seconds without blinking, longer than I could. So the other thing as well, which we found very interesting, was the fact that where there is an excess of wetting, where the tears are too much, and where there is a dearth of wetting, where there were not enough tears, we were able to show that the improvement in the lipid layer was able to stabilize tears to a normal degree of wetting on the Schirmer's paper test, where we actually put a bit of Schirmer's paper type paper onto the eyelid and measure the wetting of the eyelid. So hence the patent on the novel tear film stabilization. So we've gone and further proven concepts. We've identified HMG-CoA reductase in the meibomian glands. We're the first to do so. And also in the pilosebaceous units of the hair follicles. And I think this is an underrated area of production of the oil for the tear film. We've further gone into this, looking at the pleiotropic actions. I looked at the statins in terms of reduction of a whole range of anti-inflammatory cytokines, and also looked at their combination with dexamethasone, and showed that it can even be synergistic with steroids, which can be leading to potential new intellectual property as well. So we've ratified this further in terms of statins for treatment of dry eye, looking at the potential effects of statins on the ocular surface inflammation in a review paper through Survey of Ophthalmology, and can see here that it can have credence in a variety of aspects of corneal wounding and dry eye. So how does this all measure up? I mean, in summary, here we have a product, a novel product, which has cholesterol lowering properties, which can help with the abnormal cholesterol in the abnormal meibomian gland dysfunction. And it also has a whole bunch of lipid lowering independent effects, which basically involve reduction of inflammatory cytokines. And these compare very favorably with a whole range of competitors, all of which really address one aspect of the inflammatory dry eye cycle. Well, it's very difficult because, you know, you think you have all of these good things and still we are not yet to market. It's due to several things. It can be as basic as not even approaching the right company. A lot of the pharmaceuticals are very much into their own technology. And what we have here is repurposed old technology, just in a new form. Also, our formulation is simplistic in a way, but you know, where it's simplistic, it can also be very efficacious, but where it's simplistic, it can also be seen to be very easy to copy. And it could be an issue for people with respect to patent protection. So there are a number of other reasons which I won't go into, but to basically tie it up, we have come across a company in the States who approached us with respect to using repurposed technology. This is Embark Healthcare, and they basically have a remit to try and push forward repurposed medicines to bring them to market. And one of the key areas they've identified as well is to try and improve patent protection in terms of formulation, new formulation patents. So this is where potentially nanotechnology can fit in. So nanotechnology for atorvastatin has been used in a number of scenarios now clinically across the medical sphere. So why not with respect to the eye? So the key here is to have atorvastatin in its raw crystalline form to basically deliver it through whichever drug delivery system you have in terms of the nanosphere, basically then to the ocular surface, to then also potentially the oil glands, the meibomian glands, and also as well to the adnexal structures, to try and basically reduce inflammation to the ocular surface, and then to try and improve the health of the meibomian glands in terms of the lipid secretions. So nanocrystals are the easiest way to approach this, and it's one of the first approaches that have helped shape nanotechnology in terms of shrinking down the drug sizes to sizes which basically then engender easier solubilization, easier bioavailability, where you have really 100% of the drug without any kind of excipients. And you can see this here in this next slide, where you have larger crystalline atorvastatin, and the particles, they basically gel together. But then when you have optimized nano formulations in terms of nanocrystals, they're much smaller, and therefore they can be basically absorbed faster and made more available, and be more efficacious at the tissue structure, especially when it comes to the eye and clearance from the eye in terms of tears, which can be an issue in terms of drug clearance, where you want the eye, whether you want the drug to stay on the eye for longer. So what about other aspects in terms of nanoparticles? I won't necessarily spend a lot of time on this, given time constraints, but atorvastatin has been made into nanoparticle form. But there are issues with susceptibility to interaction with biological matrices, including mucus. And the mucus layer is actually the bottom part of the tear film. You've got the lipid layer, the aqueous layer, the saltwater layer, and then the mucus layer, which basically engenders the base of the tears. What about then micelles? And these are actually quite a good idea. And I'll come to Micellar Technology, which has already been applied for dry eye, which is already in the marketplace. So it has been already made in terms of atorvastatin in micellar form. So it is a real possibility to take on this type of technology. So liposomes, lipid bilayer vesicles as drug delivery carriers. Again, potentially not necessarily ideal for the ocular surface, as aqueous dispersion may be still considered a critical issue. With aggregation, vesicle fusion, drug leakage, and lipid degeneration, potentially then reducing the optimization of delivery to the ocular surface. So what about nano emulsions? These are fairly easy to manufacture. The techniques are already in place. They describe it as simplicity of formulation indeed. Can be cost effective, good storage of stability, and you can load a lot of drug into these carriers. And in fact, atorvastatin has already been made into a nano emulsion, an oil in water emulsion. And this has been due course for transdermal delivery of atorvastatin, so via the skin. So here's an example of a nano emulsion droplet, and the atorvastatin is solubilized in an oily layer here in this next paper in oleic acid. And this oleic acid is actually used in ophthalmic products onto the ocular surface. So they've formulated atorvastatin into an oil and water system in dermatology to actually increase delivery of atorvastatin through the skin to effect cholesterol lowering. And it's important to know that they have actually found the atorvastatin able to accumulate in skin follicles and then disperse into the circulation via this way. So it's important to recognize this, because then it then gives kind of credence to the fact that atorvastatin could be sequestered within the hair follicles of the eyelashes, and indeed also the meibomian glands. Now, SLNPs, and Ling was talking about this as well. And it's interesting to note that atorvastatin has also been put into solid lipid nanoparticles, and indeed for macular degeneration. There's a Professor Indupal Kaur in India, and she has actually put atorvastatin into solid lipid nanoparticles, which have been shown to actually reach the back of the eye. Here is one in their paper. showing encapsulation amazingly of the atorvastatin particles and of really nano size. They've done a whole variety of studies to confirm safety on the corneal epithelium as well as retinal cell lines, ocular surface tolerance, the demonstration of release through diffusion experiments, and also confocal microscopy to show passage of these solid lipid nanoparticles through to the back of the eye. Here are some examples of the SLNPs through the cornea, through the aqueous humor, through the vitreous humor, and through to the posterior tissues into the retina. But what is salient here is I don't see any pictures of any of these SLNPs in the human lens, which I think is quite significant given that the human lens does engender cholesterol synthesis to basically retain its clarity. So they found that if nanoparticle sizes are less than 500, then basically these can reach through to the back of the eye. So perhaps with respect to the ocular surface and SLNPs, potentially keeping this kind of technology around the 500 nanometer size where they can still reach the nuclear membrane could still be quite effective for the surface of the eye. So coming to nanoformulations which already exist for dry eye, there is iCurvis. And again, here you have novel formulation patents with cyclosporin, which is already a known drug, but since it's been reformulated into a new nanotechnology form, there's new novel IP. It's quite interesting. It involves the solubilization of cyclosporin in oil, and then having an electrostatically charged shell, which allows it to basically attract itself to the ocular surface. This is a positively charged shell, which then attracts to the negative ocular surface, and then increases delivery of the cyclosporin. Here you can see the electrostatic charge allowing adhesion of the nano-sized droplets onto the surface and then dispersing slowly over time, increasing drug delivery. There's also Sequa, again, another novel formulation of cyclosporin, and they have their own patented Micellar technology. Again, I mentioned micelles before, so micelles are indeed a way to deliver the drug to the eye. But it's very interesting that, where you think there's increased availability, you'd think there's also increased efficacy, and that is the case, but there can also be increased ocular surface toxicity. So a lot of my patients, interestingly, have increased discomfort and pain and stinging and blur because there's increased trapping of the drug onto the ocular surface. So better is not always the best in terms of the patient overall. So therefore, this brings in atorvastatin again, because there is still an unmet need. When we did our pilot study, atorvastatin was very well tolerated on the ocular surface. There were no issues with stinging. Here is a study just come out where this team have extensively quoted our papers to recognize that atorvastatin on the ocular surface can be a very good idea to treat dry eye. And they've basically, along the lines of hydrogels that have been mentioned before, impregnated atorvastatin into hydrogel contact lenses as a way of potentially delivering atorvastatin to the ocular surface. Obviously, there are issues with contact lenses in terms of their tolerability to the ocular surface when you're treating dry eye. But certainly, there is recognition there that atorvastatin is relevant in terms of treatment of dry eye. So coming to a close, how can we potentially approach this in the future, looking to potentially get a novel formulation and pushing this technology forward? Well, the simplest form is basically a nanocrystal suspension. So you could nanocrystallize and then basically put it into a suspension. And Professor Kaur's SLNP study did compare this with a solubilized atorvastatin in suspension. Again, this gives credence to the fact that potentially a suspension just on the ocular surface is a very simplistic way to go, where the atorvastatin is able to be given in high concentration, but not necessarily then be in enough of a concentration to potentially then affect intraocular structures, such as the lens.
Thanks, Ken. Yeah, thank you. Well, yeah, we're just about to hit 5 o'clock, so
yeah, just finishing. Thank you.
Yeah, that's right.
Yeah, I'll just finish with this. So there are a number of ways to do this, but I guess the key here is to try and keep it simple. And this is the phrase coined by Kelly Johnson, engineer for Lockheed, who designed the Blackbird. So I guess keeping it simple and also potentially smart would be a good thing. So if there's anybody out there who could potentially help us with nanotechnology design for atorvastatin, this would be amazing. Thank you.
Thank you. Thank you. Now, unfortunately, we've run out of time for question and answer, but please feel free to reach out and contact any of the researchers if you have any ideas about how nanotechnology can help some of our eye problems. I feel we've been on a great journey today. We've started with finding out about the real burden out there, the real need globally for new solutions. We've heard locally, we also have a great need, but locally we also have the potential skills and expertise to find the solutions. We have Sydney Nano, we have the SafeSight Institute, both full of world-leading researchers, and hopefully we can come together to find new solutions to restore and prevent vision loss, to restore sight and prevent vision loss. Thank you to the panelists today and the speakers for talking and giving up their time. And thank you to all the Sydney Nano admin staff who've helped put this together and the staff from SafeSight Institute. Thank you again, everybody.
Thank you.
Thank you. Bye-bye.
Thank you. Brilliant
Bye-bye.
stuff, Stephanie. Thanks, everyone.
Thanks, Stephanie. Bye-bye.
Thank you.